expect to see more of a negative deflection in this anterior precordium if it was true, just global true LVH. You should see a negative deflection here in V2 with this prominent R wave laterally. But yeah, so we have nonspecific changes in the presence of a elevated troponin. So they got a PET on her, and that's the first thing they got done. And as we talked about last time, the way this is configured is we've got the stress images and then the rest images. So each of the two rows start with stress and then go to rest. And we have short axis and basically an apical 4-chamber, and a peristernal long axis would be the equivalent views that we're looking at. We start at the apex of the heart and then go back to the base of the heart. And we're just looking straight along these and comparing the slices to one another and seeing if there's any perfusion abnormality, which would be represented by a color change within the area. So there's a slight diminished count activity here in the apex that you see here in the apex in comparison, here in the apex in comparison. And then that's mimicked down here where you see this slight reduction of flow out the apex. The most notable thing on this is the TID, which is transient ischemic dilatation. If you look at the chamber size here, it is larger than the chamber size here. That is TID. And so the question is, because that's a ratio, did the heart actually increase by 14% from rest to stress?
Steve, I guess the question would be, if you looked in the context of echo and you looked at these slices and you pretended for a second that it was an echo, particularly on the vertical long axis, that might give some clues too, I think. I guess the other point was the EKG did not look convincingly sinus rhythm on the prior strip. Maybe you saw a couple of P waves, but there was a lot of irregularity and no convincing, consistent P waves that I could see, at least.
Good point. Okay, so
I guess one other point, sorry, Steve, is in the EKG, Chris had commented on the T wave inversion.
Right.
And when you think for a second, the distribution here, and then you look at the PET perfusion images, again, if this was an echo, what conclusions might one come to, at least as part of the differential?
Very good points. Does anyone want to pick up from what Nishant was saying? Okay, well, let's briefly about TID. So this is not a physical thing. The heart did not increase by 14%. What this actually says is that there is more chamber here. So one of two things has happened. Either function is diminished so that you're having more reserve or more blood left in the chamber, or the actual wall thickness due to the amount of isotope has reduced, and so that you actually see a larger chamber size, but it is not necessarily a physical change that you're seeing within the chest. So their EF actually augments nicely. It goes from 52 at rest to 58 with stress, which is a normal finding with vasodilator. When we look at the bullseye, and so this is again, the apex is at your middle and then the base of the heart is around the outermost edge. We don't see any difference. So if we look at our rest perfusion and we look at our stress perfusion, we don't see any difference. So this would mean that there's no ischemic burden that the computer has identified. When we look at our second polar map, we do see that there is clear count reduction to that apex. And that apex is what we were talking about, where we saw that there is a little reduction. And if we look closely, you can see that this apex is lighter than what it is at rest. This is rest, this is stress, and then this would be the difference. So there is a clear reduction of blood flow out at the apex of the heart. Assessing their coronary calcium, they clearly have coronary calcium, a total score of 875, and this is just showing the LAD distribution with the coronary calcium visible. Their myocardial blood flow, if you look at their global stress numbers, these all look pretty good. The LAD is proportionally down from the other two distributions. And that shows up right here because the LAD is being counted from this around there and up like that. All of that is averaged for the LAD numbers. The circumflex is averaged over here, and then the right is averaged down here. So we see some global reduction at the apex, but not affecting the overall vascular distribution there. So if we risk score it, and again, this is a risk score that we use in nuclear medicine, it comes out to an intermediate risk scan. However, the report called it a low risk scan, and so there's a discrepancy there. And so the question is, why is there a discrepancy between the risk score and the read? And the answer, not to confuse you, is depending on the question that you're asking. If you're asking whether or not this patient is at risk of a cardiovascular event, meaning an MI, there's no evidence that there's any occlusive disease on this scan. If you're asking whether or not the heart is normal and healthy, the answer is no. There's coronary calcium, there's evidence of some TID here, and so it is not a normal heart, and that's why we have a discrepancy between the two scores. All right, if we look at the echo, so after the PET, an echo was also ordered to try to figure out what was going on with this woman. Thus far, we don't really have an answer based on what we see in the PET. So any comments about what we're seeing? So very good for the text to use contrast, because we really weren't seeing a great deal of definition there. And let's see, does this help anybody?
It's looking a little bit like apical hypertrophy to me.
Very good. So Ken, why did you say that? What's drawing you to that conclusion?
Yeah, you can see the apex, especially with the contrast images. Actually, going back to the non-contrast images first, we get bamboozled by this all the time. When you look at the four-chamber view, it actually looks like the apex is ballooned and it's kind of akinetic. But then when you use the contrast, you see, the typical ace of spades type pattern that we talk about with contrast and apical hypertrophy.
Exactly. And so now if we go back to the PET, I want you to look at the perfusion images again, applying what Ken was just saying. Do we see any similarity between the ultrasound and what's being seen on the PET images? If we look again, this would be your equivalent to a 4-chamber view. And we clearly have that ace of spades looking ventricle, which then is corresponded to what we're seeing here in 2-chamber, which is again your ace of spade appearing ventricle.
So Steve, really quick, if you don't mind, going all the way back to that EKG with that increased voltage, even though it doesn't meet all the criteria for LVH, it was still something that kind of caught my eye. Do we think that maybe that apical hypertrophy is contributing to that increased voltage as LVH will generally do?
To your point, this EKG is these T-wave abnormalities and the fact that it doesn't meet the criteria. This actually is an EKG that is very consistent with apical hypertrophy. This is the type of EKG you will see.
That was kind of where I was leaning. I'm rusty on my EKGs, but that was kind of what it was starting to tell me. I'm glad that kind of panned out.
Yeah, and so the thing is, in this case where she presents to the emergency room and she's got a slightly elevated troponin, you certainly can't differentiate whether or not this is a resolving anterior lateral MI that's causing these T-wave abnormalities versus any other etiology. And so that's why I think they appropriately worked her up for coronary disease. However, when they did the PET, they kind of missed the subtleties here, which, we see this ischemia at the apex and we see it here. We see the shape of the ventricle. And then with that EKG, I mean, it all adds up. And so the risk score identified something was going on. It clearly wasn't coronary disease, and the echo confirmed it with the utilization of contrast. So,
Steve, I might interject for a sec, just on the point. So if we look at the quality comments for the past month, there's a good number of comments from different readers commenting on either visualization of the apex or concern for apical pathology, whether that's apical HCM or, concern for clot with LAD thrombus. And the EKG can be a very nice tool for the sonographers, particularly, let's just say you're not getting great images, you think the images are foreshortened, and you want to get a better sense. Maybe for whatever reason you can't give contrast. The EKG could be a very nice clue. And in particular, that V4, V5, V6 really localizes to the apex. So if you look in the chart, you have a normal EKG, especially at V4, V5, V6, it gives you a clue that things might be okay. But if you have an EKG like this at V4, V5, V6, you really want to get into that apex and do everything you can to better resolve that or make it clear that you could not resolve it. But I think as far as QA comments, there's a good number of comments. So maybe just to enhance people's sensitivity to what's going on in the apex. So the differential here, it could be amyloidosis or infiltrative disease. And so that is almost the complete negative of what you'd expect with amyloidosis, where you'd have apical sparing. So strain really helps with sussing out the differential in this case, whether or not the tissue at the apex is abnormal versus normal.
great. Let's go to the next one. Another older female seen in the emergency room again with shortness of breath, diaphoresis, and she's visiting from California, but she also shows up with a mildly elevated troponin. She has risk factors for coronary disease of diabetes, as well as hyperlipidemia. So again, she's admitted omitted for the kind of the top two, the PET and the echo. And this is her presenting EKG. She came to the emergency room. Any comments about this? It's not particularly the cleanest EKG, but so she's having some ectopy, some premature ventricular contractions that you can see throughout the EKG. She's in sinus rhythm, and she also has some nonspecific changes, more isolated to just 5 and 6 that you're seeing with some over in lead 2. So really a non-diagnostic EKG for answering any of the questions that was going on. So her PET is here now. If we look at her PET, she also has TID on this exam, but she has a clear perfusion defect that we see, and we see it out towards the apex, and we see it in basically your 4-chamber view as well as your parasternal long view, that you're seeing this apical defect. Now, it doesn't really change significantly between rest and stress, and you could argue that it's even a little better with stress than it is at rest, that there's a little more tissue visible there than there, a little more there than there. So if we look at the bullseye now, again, our apex is right here. This is rest, this is stress. The computer's calculating some difference of 20, and that's the severity of lack of blood flow out here. And then it drops down to 12, but that there's no ischemia. There's nothing that gets worse when we look at this. Her EF drops. It starts at 37 and it goes down to 31 with stress, so that's abnormal. Because with any exertion, what should your EF do? I'll give you a hint, it should go up. The polar map now, when we look at it, the apex really is spared, not showing any perfusion augmentation, and we've got some mild reduction around the mid and the base, especially towards the lateral wall that we're seeing on this. Her CT is interesting because she has a moderate-sized pleural effusion, which could account for some of her symptomatology. She has coronary calcium as well, but you can see that she does have a moderate-sized effusion. And when we look at her blood flow, it's globally reduced. And so we're not really seeing anything fixed here where there's evidence like on the other one where we saw an actual ischemic event where you saw on stress that there was a significantly less blood flow out at the apex. Now we're not seeing anything that matches with any distribution. And in fact, the apex increases in the anterior wall, its blood supply with the MBF. So when we score this, she does score a high risk PET scan for something going on. However, it doesn't, again, it doesn't look like it's necessarily coronary disease because we're not seeing any true ischemia. So this is read as an intermediate risk scan with the possibility that that was just an apical MI and without any peri-infarctional ischemia. So an event that was resolving certainly could justify why the troponin was mildly elevated, and there is a wall motion abnormality out there when you look at the gated images on the PET. So she then follows up with her echo, and So what do we think of the apical wall motion at this point? Does anyone have any comments?
Maybe just back to that earlier point, Steve. I think when you go back to the EKG there, you do see PVCs, and again, they're in V4, V5, V6, suggesting that the PVCs are originating away from the apex, as well as the deep T-wave inversion. So that would be one where you look at the echo and you might just say, hey, you don't have the PET, obviously, but you might say it's foreshortening. And so this, again, in V4, V5, V6, you have a clue that, hey, it's worth spending more time in that apex, that it's not just foreshortened. Clearly, it's not moving well, but it's also rhythmogenic.
Mm-hmm. Anybody else want to tell me what they're seeing here? Anything different that you wish they would have done with this echo?
Were contrast images done, Steve?
No. No, there were no contrast images done. You have no strain.
Rats. Probably an echo I did.
I have no idea whose echo this is.
I'm kidding. Now, some strain or not strain, but some contrast images may have been nice if the patient didn't have a sensitivity to it. And then to Ken's point, in the previous case, some strain might have been helpful as well.
Okay. So I think those are just points to remember. So the interpretation was that there was this apical wall motion abnormality, and so they centered on to coronary angiography. So here's the coronary angiogram of the left side. So we're seeing the LAD coming down here and the circumflex is up over here. No obvious occlusions from that view. Continuing on the left side, again, we're not seeing any obvious lesions that would cause an occlusion. We look at the right coronary artery. Right coronary artery also looks good. So why would we have a perfusion defect and a wall motion abnormality in the setting of normal coronaries?
I know it doesn't quite fit all the criteria for a Takotsubo's cardiomyopathy, but maybe something to consider is this person had an emotional hit lately?
Well, all we know is she's traveled from California here to visit.
Gotcha.
So,
what about some sort of coronary spasm?
All right, so you could have coronary spasm, or you could have, and if we look in the mid to base is hyperdynamic. So the diagnosis was Takotsubo's. And what supports that is if we go back to the PET, stress testing is not therapeutic. We should not see increasing perfusion with our stress agent. If this was truly an infarct area, the tissue would have been clearly damaged. It would not improve with our vasodilator. So in all likelihood, the vasodilator helped overcome what we assume is a big catecholamine release and causing the vasospasms. So it helped relax that, and we actually had better isotope coverage out in the apex than we did at rest. So that helps support this being Takotsubo's over an MI secondary to just coronary spasm. And when we've looked in the past at recovery from Takotsubo's, I have another case that we did serial. This was written, we wrote this case review up, but they, if you look at their perfusion markedly improved 2 months later and was nearly normal without any intervention. It was all secondary to Takotsubo's. All right, this is a very complicated, convoluted case, and to me it points out some limitations of our ability to image and the need for everyone to review previous studies. So this is a older female who had a tissue valve, aortic valve replacement in 2013, and then subsequently came back in 2018 and got a TAVR due to dysfunction of the 2013 valve, and then in 2019 developed positive blood cultures, had a TE up in Boise that didn't show any visible or obvious vegetations, and then got sent down for further evaluation. But she did clean up her blood cultures after 6 weeks of antibiotics. So this was her original in 2018 prior to her TAVR presenting EKG, which really just shows sinus rhythm with some ectopy, but nothing markedly abnormal. Her TEE echo at the time of the TAVR, this again is 2018, shows the dysfunction of that prosthetic valve that she has and some mitral regurgitation as well. This is the original tissue valve from 2013 that you're seeing. So there is obviously stenosis and some regurgitation through that valve with a really markedly abnormal leaflet that you can see at the end that's heavily calcified. When you look at your 3D imaging, that valve is not functioning well at all. And this is what you see in case you guys haven't been in to one of these cases. This will be boring, but this is the balloon going up, and they're pre-dilating the valve that's currently there, the 2013 valve, to make room so that they can put in the TAVR valve. And so that's what you guys see when by TEE when you inflate the balloon. You notice that they're pacing the patient very quickly to help prevent flow, and then they resolve that. This is the expansion and the actual implant of the valve itself. And then they're going to stop pacing. And there's restoration of normal flow. So this is when the valve's done, and we notice that there is an echo-free space after the valve has been put in. And that's really what I wanted to point out, is after this valve in valve, you do have this significant echo-free space around the valve that has some flow in it. And this will become somewhat of an issue later on, because you've got thickening around the aortic root as well as an echo-free space. Now you know that this is an infection because this is immediately post-op. But if you were to see this a year later in the setting of somebody with positive blood cultures, how and is there any way to differentiate between infection and or just normal post-surgical intervention? So the TE showed that it went well. They were able to put a 23 millimeter Sapien valve in, and they're able to do that into a 21 millimeter old valve. So this is what they see in cath when they inflate the balloon. That corresponds with what you saw in echo. So this is just pre-dilating that valve, and you already saw the echo clip for what's going on. So this is the exact same instant by cath and by echo. So they fractured that valve.
Yeah, they fractured the previous valve. So
right, that's what they were doing, was fracturing the valve right here, and then we're able to put a 23 millimeter valve in to a 21 millimeter previous valve. So unfortunately, she went back up to her room, and she ended up decompensating rapidly, ended up getting on ECMO and brought down emergently back to the cath lab because she was in peril. And you can see the overlapping valves now, so you can see the outline of the original valve and then the hexagon matrix of the TAVR valve. And so she was brought back down, and this is what they found on cath, and this is the left main. And so the left main has now been gelled and occluded, so they're dilating the left main. They end up stenting the left main and opening it back up, and they leave the stent, and you can see the stent here actually protruding into the aorta. And here, that notch that you see is where it's actually going into the left main coronary artery. So you can actually see it sitting out here in the aorta. So this is the report after dilating. They used a very large stent to open it up. So when she comes back in 2019, now this is after her blood cultures and after the TEE up in Boise, which didn't show any vegetations, she now has a complete right bundle and some poor R-wave progression out laterally, and this could represent some damage from what went on with that left main stent. So they did not repeat the TEE down here, or they just did a surface echo. And again, we're seeing echo-free space around that valve. But functionally, to my untrained eye, the valve looks like it's functioning well. But we do have this echo-free space here. And now we have a patient who is blood culture positive, who has a clear echo-free space around the aortic valve, and now you can actually see the left main stent protruding out. Her function looks good. We don't see any wall motion abnormalities. And the aortic valve is not well visualized, but you can see some motion there. And then your 4-chamber view again. Not appreciating any regurgitation. There is a little mitral regurgitation, but the aortic valve is all appearing normally. So shows a normal functioning valve without any abnormalities. The left main stent appears to be where it should be, and working well without any wall motion abnormalities. So how do we differentiate now whether or not there's infection in the aortic root if the TEE has baseline abnormalities the one test that nuclear medicine can do for you is we can do a PET with FDG, and FDG is radioactive glucose, and we see glucose metabolism within tissue under variable circumstances. So depending on how we prep them, we can see evidence of infection, or we can see evidence of viability or inflammation as well. So if you have an infiltrative disease such as sarcoid, we use FDG to identify that. So we have is again the perfusion imaging above, and then this third row now is the imaging with the FDG, and the top two rows are just like we've been talking about, stress and rest. So if we look at the perfusion, this is, I should have lined this up. I'm a little misaligned here, but if we look kind of diagonal to one another, you can see that the perfusion all appears to be normal. There with FDG, you can see that we don't have any uptake of FDG within the myocardium. If you look closely here, you see the RV blood pool and you see the LV blood pool, and then between you can actually make out where the septum is of the ventricle. And then we start to see a lot of FDG uptake as we start to get out towards the base of the heart. From our 4-chamber view, you can see the interventricular septum, lateral wall, blood pool here for the actual chamber, and then uptake here. What lives right there on your 4-chamber view?
The aortic valve.
There you go. So that is uptake around the aortic valve. That's what we're seeing on this PET. We don't see any perfusion abnormalities. Her EF augments nicely. She has microvascular disease, which would go along with a history of aortic stenosis as well as left ventricular hypertrophy. There's her left main stent. She doesn't have any other coronary calcium, but she does have that left main stent sticking out. And her blood flows are down globally. So this was interpreted as a low-risk scan for perfusion. And when we look at her FDG, her whole body, from an AP perspective, we don't see much uptake, but there is some uptake right here. If we look laterally, now we can really isolate it to the aortic position. When we go into our slices, you can actually see the uptake, and she actually meets criteria when we measure blood pool in comparison to what the count activity is around that aortic valve. There is a significant increase of uptake in comparison to what background is. And so subsequently this was positive. So she does have an infected aortic annulus around the valves. In her case, because she was culture negative, and her age and the fact that this would be a third time in, they opted to treat her medically with just suppressive antibiotics and follow her symptomatically, is what they opted to do for her. So any questions or comments about that? Does anyone have any idea how we could have defined with echo whether or not those echo-free spaces were infected or not?
Been doing echo a long time, Steve, and there's nothing that I'm aware of that would help us to kind of sort that out.
Yeah, I don't know of anything. I mean, and to me the key is when we go back and we looked at that 2018 echo, and you could clearly see that there was echo-free space around that valve post-procedure. I think that kind of made things difficult, if not impossible, unless you saw an actual vegetation, to define whether or not you were going to deal with infection down the road.
Yeah, I would agree with that.
I don't know.
I'm here, but I have been paying partial attention because my patients are coming in clinic. Sorry, what was going on?
Well, I was just asking if there was any technique, so the last case we looked at, I don't know if you were paying attention to it, but they have a valve in valve, and they had echo-free space around immediately post valve in valve, and then came back later with positive blood cultures. And so my question was, normally when we see that echo-free space around a prosthetic valve, the first things you worry about is whether or not that's evidence of a pocket of infection. But if you start out knowing that there's echo-free space around this, do you have any tricks or any suggestions on or possibilities how you would differentiate echo-free space?
Great question. Yeah.
That is there post-surgically versus what would be seen with infection.
There are a couple tools we have in our toolkit, one of which would be following the echo-free space on TE over time. So that's a conservative way of looking at it. Maybe a less conservative way would be to do follow-up CTA imaging of that. That is known to have a better sensitivity for both and specificity for abscess in the setting of the concern for endocarditis. So I think between the two, you have a couple options, but definitely agree that if we're really looking for active infection in the setting of prosthetic valves, I think a cardiac PET CT is probably our best option. Okay.
I was just curious if we were, if we were missing something or if there was some technique that should be used by echo for those circumstances, which it doesn't seem like there necessarily is. Okay, great. Well, let's go on to another case. So we have an older gentleman who has some mild shortness of breath, is otherwise denies symptoms. He does have a history of moderate AS, and that was documented by an echo in 2019. He ended up having a coronary artery calcium score in 2021, which demonstrated that he's got significant coronary calcification. His only risk factors are hypercholesterolemia and hypertension. He does have renal failure, so he was sent for his PCP for further evaluation with an echo and then a PET to try to assess whether or not this calcium is significant for obstructive coronary disease. His EKG is here, and it shows a fairly prolonged first AV block and some, again, non-specific changes that we're seeing, but otherwise it's a normal looking EKG. This is his echo. This was done at Park City. And you can clearly see that the aortic valve is abnormal and thickened. Look at it in short axis. The right coronary cusp is predominantly involved and does not appear to be particularly mobile. His function looks reasonably good. We're not seeing anything other than some left ventricular hypertrophy, but no wall motion abnormalities. And his velocities are about 4 meters per second. Now, this does represent an increase from his previous echo. So the valve is progressively getting worse, but they still interpreted that as moderate. So any comments, anything that they should have done different, because they did do blind CW. Is everyone satisfied with the quality of the Doppler signal? Do you think they should have done anything different? Tried harder, or is that all good data for you?
That jet starts at the QRS. I would say that's probably MR being imaged there. Your jet should start after the QRS starts, and it's right at the edge of it. I don't know. I would have to see a better image of that.
I would have liked to have seen a little more Doppler on this study, and these were the best ones I could pull out of it. But yeah, to clearly define what MR looks like and what the aortic valve looks like.
Right.
All right, so they came for a PET. Again, he has marked TID. You know, we're talking 24% difference in that chamber size from rest to stress. So that's a very significant, and I think visually, I think everyone can appreciate the chamber size here to the chamber size here, that it markedly increases. Even when you're looking in your 4-chamber view, the how small that chamber is to how wide that chamber is. Also, this scan to me really points out what I was trying to express, how you see how thick this wall is, and you can visually see how it's thinned out. And so that's why we get these TID numbers. It's not that the ventricle actually grew by 25% within this person's chest. It has to do with how much chamber is available. And so the inferior wall, again, this is a little difficult because his gut is in the way, but you can see that the inferior wall is affected with count reduction. You see that also up here, that it's the inferior, predominantly the inferior wall that is affected. If we look at his EF actually drops. It goes from 78 down to 73. You will find some readers that argue that if EF above 70 is normal, and they kind of discount this. But any drop is significant in my mind. If we look at the polar map, now you see at rest, the perfusion looks pretty good. And then with stress, you can see how this is all markedly reduced. So this would be ischemia. Our other polar map shows this RCA distribution ischemia with some apical ischemia as well. He does have significant coronary calcification with a score of, we got 2,041. However, the techs were also able to identify a non-coronary calcium score of 3,827. And that would all be located right here on the aortic valve. So calcium, just so you know, the correlation between calcium and significant aortic stenosis for men, a calcium score on the aortic valve greater than 2,000, and in women it's greater than 1,200. That correlates with about a 93% specificity of significant aortic valve disease by calcium. So we've got MBF now. If we look at this, the curves, which I won't get into, but these are not the best time activity curves. So this is when we injected the isotope and as it passed out of the ventricle. There's some issue there which will cause some variation over here. But what we see is globally that this is markedly down. When we look at this map, it really looks like just circumflex and first diag are are perfusing well. Everything else is, with stress, is hypoperfused. So what happens to perfusion with aortic stenosis? What's the big concern about exercise with aortic stenosis? Why don't you do an echo with somebody with critical aortic stenosis? You don't do a stress echo on them. Why don't you exercise them?
For hypotension and possible syncope.
Okay, so what causes the hypotension and the syncope? Why would aortic stenosis cause that? All right. With aortic stenosis, you can get a phenomenon called global ischemia, where the entirety of the ventricle is hypoperfused, and that can cause marked reduction in contractility, marked reduction in EF, and so that's what causes the hypotension and can cause you to be syncopal. It also, if it progresses, can cause retractile ventricular arrhythmias and subsequently cause death. So that's why critical AS should never be exercised. Now, we just did a vasodilator on somebody who has significant aortic stenosis, and we see the same phenomenon occurring. We see TID, which is something we see with global ischemia and significant ischemia. We see the EF dropped when we did the stress on this individual. So we're seeing the same effects that you would see. However, it's a little more controlled and it's not as severe with the vasodilator as it is with physical exercise, because we're not driving their blood pressure or trying to drive their blood pressure up as well. So this guy hits a perfect score on my risk model. He gets a 9 on it, and so this is a high risk scan, and this is consistent when we see these numbers where he's got ischemia superimposed upon significant aortic valve disease. That's why this scan is so abnormal. And when we look at his cath, when we look at his left system, we see some disease in the LAD distribution. And when we look at his right, we see a great deal of disease in his right coronary artery. So they subsequently stented the right coronary artery, and they did cross the aortic valve, and he does have severe aortic stenosis, even though the echo, back to Chris's point, which probably was contaminated flow, did not clearly define the severity of the aortic valve. It turned out to be significant. They deemed the LAD to be moderate. However, they're going to reassess it when they bring the patient back for his TAVR after we went back and looked at the PET images. They'll reassess that, hopefully with IVUS, to determine whether or not intervention needs to be done. My point with this is that one, PET, you can differentiate both, multiple abnormalities by PET. And then my second point was for you guys to be a little more vigilant and clearly define what MR looks like and what the aortic flow looks like. That's all I have. Comments, questions?